All right, hi everyone. Thanks for joining the School-Based Health Alliance for our webinar, More Than a Model, Upstream Innovations in Adolescent SBIRT. In this panel discussion, speakers will explain the rationale for expanding the SBIRT model beyond substance use. They will discuss how context, developmental, cultural, and socio-political can influence adolescent SBIRT and implications for health equity. Panelists will describe upstream interventions for adolescent health and discuss how they can support youth in functional ways. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based healthcare. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack access to healthcare services. School-based healthcare is the solution, bringing healthcare to where students already spend the majority of their time, in school. When health and education come together, great things happen. Attendance improves, conditions like asthma or diabetes are better managed, and behavioral health issues get quick expert attention. And we all know that healthy students make better learners. Now we have a few housekeeping reminders. All attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the Q&A tool located in your Zoom control bar. We will address questions following the presentation. If you would like to add your comments through the chat function, please select all panelists and attendees before sending the message so everyone can see it. We also have closed captioning for this webinar. To turn it on, click on CC or the closed captioning button on the Zoom control bar. At the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website in 1 to 3 business days. Please also visit the School-Based Health Alliance for additional archived webinars for example, the first session of this SBIRT series. Our 2021 School-Based SBIRT Speaker Series is funded by the Hilton Foundation. In early May, we will host a panel focused on the connection between the SBIRT model and comprehensive screening. We are so thankful to our colleagues at Community Catalyst who have graciously allowed us to rebroadcast 3 sessions from the recent convening on policy advocacy to prevent addiction, and we invite you to join us for those as well. I'd like to introduce my colleague, Katie Stinchfield. Katie is a senior program manager at the Alliance who oversees our behavioral health work. Katie is joined by Emily Baldi, the programs and consulting associate at the Alliance. They will be facilitating today's session. I will now hand it over to Katie to introduce our panelists for today.
Thank you so much, Maddie, and welcome everyone. Our panel includes Evan Elkin, the Executive Director of Reclaiming Futures. He is a nationally respected innovator and leader in the field of juvenile justice reform, adolescent and family mental health, substance use treatment, and youth development. Evan is the developer of a number of innovative approaches to screening, brief intervention, and referral to treatment, designed for schools, youth justice settings, and tribal communities. Rebecca Goslin is the Director of Clinical Initiatives for the Colorado Association of School-Based Healthcare, providing programming support to and advocacy for school-based health centers across Colorado. She is a licensed professional counselor and a licensed school counselor, and enjoys uniting her passions for behavioral health and education in her previous role as a behavioral health provider at a school-based health center, where she used SBIRT almost daily in the integrated care clinic. Bree Ryman is the Assistant Vice President for Practice Improvement and Consulting at the National Council for Behavioral Health. Having previously directed the SBIRT Colorado initiative, Ms. Ryman has extensive experience working with hospitals, primary care, and behavioral health organizations to change organizational practice to enhance healthcare access and delivery. Ms. Ryman has provided training nationally on SBIRT and motivational interviewing, integrated care best practices, and practice transformation in diverse settings. Brett Harris is a senior research scientist in the Public Health Research Department at NORC at the University of Chicago, and a clinical associate professor at the University at Albany School of Public Health. Dr. Harris has over a decade of experience developing, implementing, researching, and evaluating SBIRT projects in multiple service settings. Over the past 5 years, she's focused efforts on an expanded SBIRT model, which integrates suicide risk screening and intervention. Baila Salifu is a youth project intern for the School-Based Health Alliance and Play to Prevent project through the Yale School of Medicine. She's also a member of the School-Based Health Alliance's Youth Advisory Council and a freshman at George Washington University. Violet has been involved with local hospitals, mentoring youth through Army education, and promoting cultural awareness through her language immersion experiences. At George Washington, she studies global health and hopes to understand how to improve healthcare disparities. So now we would like to ask our panelists our first question. We'll kick it off with a brief description of your work with adolescents, including youth substance use prevention and SBIRT. Evan, do you want to start?
Sure. So the organization that I run, Reclaiming Futures, has its origins mostly a focus on the youth justice systems around the country. So talk a little bit about that and how we came to this idea of focusing a lot of our attention on this concept of SBIRT. But we have since, as you'll hear, in various of my answers, focused a lot upstream on school and community settings, and talk about the philosophy and impetus behind that. I think that's kind of the theme of the panel. But working in justice settings and the various youth serving systems, we have a kind of a fundamental understanding that the ways we define problems are typically challenged and made more complex by issues of justice and equity, and some of the issues faced by the populations that tend to populate either justice systems or tend to be the ones on the fringes in school settings, those frequent flyers in discipline kind of conversations. So our understanding of screening is that by making it more participatory and making it more kind of responsive to culture, as opposed to what has typically been kind of a passive case finding or categorizing or sorting exercise in public health, you do a sort of what we think of sometimes as a piece of social engineering for the systems themselves. So our organization is really not directly a prevention and substance use treatment organization. We consider our crosshairs to be the systems where kids tend to populate and where the public health opportunities reside. So that social engineering is about helping the decision makers in settings like schools and justice systems to appreciate the whole kid and the whole culture by making screening and SBIRT a collaborative conversation. And for us, that's a social justice maneuver as well as a sound public health maneuver to let people take the lead role in writing their own wellness script. And from a cultural standpoint, to bring their norms and cultural concepts of wellness into that conversation, not simply answering questions and awaiting a diagnosis and a referral, but to really write the script themselves. So that's kind of the philosophical core of what we do.
Thanks so much, Evan. Same question for you, Rebecca.
Well, I have worked with adolescents, starting at a community health center, transitioning to being more present in the schools on an alternative high school campus, and then moving into being a behavioral health provider at a school-based health center on that alternative campus where I learned about SBIRT. And all along the way, I think working with youth, substance use comes up. And so substance use prevention comes up, whether that's with families, with the youth themselves, with concerned adults. It's kind of always around the periphery. And I think one of the things that I found is that SBIRT in general, it quickly just looks so much bigger than substance use. Because when you start to talk about youth, about substance use, you really start to peel back the layers of other behavioral health concerns, relational concerns, school concerns, community concerns. And so I found that working with youth pulls all of that together, and often just finding out, why they tried that first cigarette or what they love about vaping, that you find using those motivational interviewing skills, using those screenings, there's a lot there. So that is a brief overview into my personal work with adolescents. Seeing school-based health centers around the state of Colorado, what I see is that It's an opportunity for these conversations to start early on. School-based health centers are usually serving youth from sometimes early childhood all the way up through high school. So they have a really unique opportunity to engage with young kids in child check settings and start these conversations and gain trust of families, and then build these conversations based on that trusting relationship over time. And so I think it becomes much more of a natural destigmatizing conversation when it gets partnered in a primary care setting, and also becomes one that isn't just about working with adolescents, but becomes a natural just part of checking in with youth across their lifespan.
Awesome. Thanks, Rebecca. I'll ask Bila now, our youth speaker, your background on this.
Yeah, so my main role, what I pretty much do, I'm part of the video game intervention. It's called Play Smart, developed by the Play to Prevent Lab in collaboration with the School-Based Health Alliance and Shell Games. So Play Smart is really geared towards opioid misuse prevention, and it's one of the many games created by the Play to Prevent Lab. They've made Smoke Screen, which is about smoking and vaping prevention, and Play Test, which is all about HIV prevention. But looking specifically into Play Smart, it comes with 6 storylines or 6 mini games that each sort of have different roles to play when it comes to opioid misuse. So as we all know, it's a very complex topic, especially when we're talking about adolescents. So it's really important to take a more holistic approach. So there's peer pressure and personal advocacy, mental health awareness, and knowing how to get help, and also how to even navigate a loved one misusing opioids. And my main role was providing feedback from a youth perspective to make sure the game was as realistic as possible, just because it's a very, very different way to approach opioid misuse prevention that really targets youth specifically, and in a way that's more so subtle, because we're putting them in these different situations. And my role really was, I attended different game development sessions, and I had to change some of the language just to make sure it aligned with what youth say today. So it's a really very, very unique approach to substance use prevention, and is of course an extension of the ESPER model.
Awesome. Thanks, Byron. Brett, can you give us an overview of your work?
Yeah, well, I started in ESPER, I think it was like 11 years now, and I took a position with the our New York State Office of Addiction Services and Supports. So I mean, of course, never heard of ESPER. But essentially I was just told to, okay, this is what we're doing, and I want you to come up with something else. So of course, I automatically think of adolescents, because the upstream and how much impact we can have over the course of a lifetime, rather than working kind of later on with adults who have already started, maybe experiencing some problems due to substance misuse. So you get kind of that, biggest bang for your buck. And so I, of course, go to schools. So kids are spending all of their day, in schools. This is a real opportunity, but of course, identifying many challenges with that located directly in the school setting. So the first thing that comes to me is school-based health centers, because New York State has a very large network. So there wasn't a lot of ESPER implementation in that setting, at least what I was looking around for. I was like posting messages in like national national kind of listservs and stuff. And of course, I reached out to Bree, who's the panelist, and I don't know if you can remember that, Bree, but I was asking about different experiences. I know Colorado was doing ESPER in school-based health centers at the time. So we eventually led to piloting ESPER in some school-based health centers downstate in New York. And we had pretty good feedback on that. So we ended up doing some additional projects upstate and then just trying to spread that. But the issue that we had was implementation and getting voluntary adoption. So I ended up actually doing, I was in my doctoral program and ended up doing my dissertation with school-based health centers, surveying medical directors and clinicians to find out what are those factors that either facilitate or impede voluntary adoption and implementation of SBIRT in school-based health centers. So this has been a real interest of mine, like the Pacific School-Based Health Center, Adolescent, SBIRT, and have worked more recently trying to figure out how you pull the opioid crisis in, just to get more school-based health centers saying, yes, like we need to do this because this is the issue of the time.
Thanks so much, Brett. So that seems like a natural connection to Bree.
I do remember that, Brett, by the way. It seems like 100 years ago, but I remember that connection. So as Katie mentioned, I had the great opportunity to work with Colorado with an organization called Peer Assistance Services, where we, had initiated SBIRT training for healthcare professionals across the state, and school-based health centers was part of that sort of collective. And so sort of went on the road and trained really primary care providers, hospitals and other clinics on integrating SBIRT into practice. And with that work, it was, gosh, a decade ago, we really started to look at piloting, screening questions for opioid use. And we were kind of on the front end of that because we felt that screening for alcohol use is so important, as we know alcohol use and the prevalence of alcohol use, but also knowing that, co-occurring substance use is part of that. So wanting to branch out, wanting to screen for opioid use, wanting to screen for adverse childhood experiences. And so we looked at ways to pilot with the clinics we were working with different screening approaches. And I remember one site visit in particular in Basalt. So if you've ever been to Colorado, Basalt is kind of a smaller community on the Western Slope, and we trained this clinic to screen for substance use and adverse childhood experiences. And it went over really well, but it really took the buy-in from the clinic leadership, and we just learned all these lessons about how a champion is like one of the #1 things you have to get within an organization is somebody to really champion and believe in the work that you're doing. So I did that work for several years. Now I'm at the National Council for Behavioral Health, where, I'm a little farther removed from the direct provision of training and technical assistance. But what I do get to do is strategize the connection piece between. So for example, I was an advisor as part of the development of the change package. We have an SBIRT change package where we brought together experts from across the country to evaluate the research and come up with recommendations both for youth SBIRT and adult SBIRT, and then figuring out how that connects to these opportunities we have at the National Council for Youth Mental Health First Aid. If we're training people on youth mental health first aid, shouldn't we also be training on SBIRT and some of these other collaborative public health approaches? We're also working a lot. The National Council is really pushing forward the agenda for certified community behavioral health clinics, which is really, in my mind, the way mental health and substance use services will be provided in the future. It's sort of the sister model to the federally qualified health center and provides like a sustainable backing for mental health and substance use services. And so making sure that SBIRT is a core component to the CCBHC movement across the country. So I get to work at more of a systems approach and figuring out how to make these connections across these different interventions and really, wrap around the services being provided in these.
Thanks so much, Bree. And I feel like many of you already sort of addressed this question, but follow-up question. What prompted you to expand your SBIRT work beyond substance use? So when you started looking at all of the other factors that felt important to address, what led that thinking? And I know, Viola, I know you're on the leading edge of that already, but would love to hear just sort of the process that you went through. I'm going to switch it up and I'll ask Brett first. What made you start kind of expanding your thinking?
Yeah, I think seeing the intersection of substance use and suicide. So I tried to hold back on my first response because I didn't want to, I wanted to be able to answer some of the follow-up questions. But essentially, I left my position at the Office of Addiction Services and Supports to the Suicide Prevention Office at our New York State Office of Mental Health, and immediately saw that connection, as well as how best practices in suicide prevention fit into the SBIRT model so well, the screening, the safety planning, intervention, and follow-up. And just the intersection of the two issues, and particularly now, like suicide is, like the way I see it, is like a hidden contributor to the opioid crisis. And first of all, just kind of the clearly looking at it, you see that some of the suicides that are by drug overdose, there's issues in classification of that. So essentially, about a third of suicides don't or only about a third are accompanied by notes. So it's very difficult to determine intent. And the misclassification is greatest with overdose. So you see that whereas about 6 to 7% of those overdoses are attributed to suicide, it's really about 20 to 30% is what the estimates are. You see that, and also people with opioid use disorder at 6 times the risk of suicide than the general US population. So can we, and then the other piece is that, like some of the other panelists were saying, that opioid overdose is very downstream, and often opioid misuse is preceded by alcohol or marijuana use, particularly among adolescents. And if we can do what we can to address that crisis, we can do that through SBIRT, kind of upstream for alcohol and marijuana use with adolescents who have, the lowest opioid overdose rate, but it quickly jumps up in young adulthood, but also addressing suicide risk. And just because that model is there and it fits well, and coming from the SBIRT field, we know that we want to increase uptake of SBIRT is not being done enough. Suicide screening and interventions being done less frequently than SBIRT. So we figure, like, if we can put this in here, like into this model, that there's more of like a presence, that we can increase screening for suicide risk as well as intervention. That way you can address these like 2 major issues. I think you'll see positive outcomes for both of them. Even if your risk is only identified for one of those issues, I think you'll see positive outcomes for both of that.
Thanks so much, Brett. Bilo, would you like to comment on this one?
Yeah, so I think that the video game in general is a very, very, it's more so to be looked at as like a preventative tool, just because a lot of the approaches to substance use, as Brett said, is very downstream. So when there is the overdoses or the substance misuse, and I think we can all agree that it's a lot easier to prevent these problems than actually having to treat them down the line. So the video game is, again, very much centered around putting a lot of emphasis on what happens when you, I guess I don't want to say make bad choices, but when you don't consider the consequences of the action that you're taking. So, which is really cool, because you get to almost make these bad decisions, and then you end up in the future where the consequences happen, and then you get to go back and see, okay, here's what I can change. So it's a really, really great way to sort of put youth in that position where I am also in charge of my decisions, and I can make that choice to either put my life where it can be in a way that's not going to benefit me and my family, or I can make that decision to think about everything that goes into it. So it's really a way to almost change the trajectory of youth and adolescents' life down the field, as a lot of opioid misuse or just substance misuse in general starts before the age of 18. So now we're able to tackle these issues where they start and at the root, which is, again, I just keep saying it's unique because it is. I think it's really great, and it could really, really benefit a lot of youth, especially if it's a video game at that, and it allows a lot of access to people who may not even know, okay, here are the consequences. So that's my take on that.
So thanks, Myla. Bree, how about we'll circle back to you. What prompted some of your thinking? I know especially this connection to youth mental health first aid.
Yeah, and I think what prompted us to think about SBIRT as like a public health approach was really working with the clinics directly and understanding the needs of the population and using the data to inform the practice. So what was the prevalence of substance use and other issues within that community, and how do we adapt to use that as a framework to address other issues? So it was really just matching the community need and the provider need, and then working alongside those clinics to implement a model that worked for them. And I would say that we really customized and tailored our approach to the needs of the community and the population they were working with. And I think we continue to do that today. I think there's a lot of untapped opportunities that are sometimes restricted by the way things are funded. As you know, I've worked for pretty much my whole life on SAMHSA funded initiatives, and sometimes there are restrictions. So getting creative on how you match funding with other funded initiatives, or invest your own matching dollars to branch out. And I think that's critical to some of the work that we do. And you also know that the data requirements for some of these grant funded initiatives, how do you use that data to tell a story and to inform your work moving forward? And I think we've gotten really creative in our approaches and how we do that, and how we sort of harvest that data and that information to tell a story and then to inform our work moving forward. And so I think the youth mental health first aid tie-in with the SBIRT funding, there's a lot of traction with mental health first aid, really on a global basis. It's traditionally focused a lot on mental illness. So of course, in my mind, as somebody who thinks who kind of grew up in the substance use prevention space, equally important as addressing mental illness. So thinking about how we use mental health first aid to help continue to chart our path with SBIRT sort of adoption across the healthcare community.
Thanks so much, Bree. Rebecca.
So that fits in really well with the direction that I saw SBIRT moving when I was working at a school-based health center, that I continue to see it go, which is looking at what the screening data shows. That I think was a large part of where it started, is that substance use doesn't happen in a vacuum. And when you're talking about early use, you're talking about a complex issue that is not one thing. And we saw that loud and clear on the screenings that school-based health centers are doing. So most school-based health centers that are screening youth under the SBIRT model are also simultaneously at those visits screening for depression, they're screening for anxiety, they're screening for ACEs, they're screening for other risk factors, they're screening for social determinants of health. And when you start to look at the full picture, it started to make very little sense to only focus on substance use. I also have to say my direct work with youth really informed my personal practice and my encouragement of the school that I worked with to establish an alternative to discipline model using SBIRT, because what we found is if you could get the youth, it's an identified problem and it's a problem behavior. So it could be a kind of red flag that pops up as far as substance use goes, but really it was a great opportunity to address more going on. So to be able to talk with youth, what I found is most of them are not really interested in stopping whatever substance use behavior they're engaging in as the first step. It's not where they're at developmentally. And so if you step back and you find out what else is going on and what areas that might be a concern to everyone, the youth included, that they are willing to take a step in. What we saw at our clinic and the school saw by doing this alternative to discipline was that if you get the student to recognize there is a problem of some kind and they will name that, then you can get them to say, I'll try this. So if it's they're bombing out of English class every day after lunch because they're getting high during lunch and they care about staying on the track team, you start to work with them of, okay, well, how can you stay in English class? And you find out that they're really stressed out about something in that class and you work on that. Or maybe it's a learning issue that they need support with. But what we found was when we started to just expand the picture, youth buy-in was better. We got better results on more concerns than just the substance use, and we still got to the substance use within the process. So it was just a really natural progression of looking at the data in front of us, and then letting the youth feel empowered, which is a large part of SBIRT, is meeting youth where they are, and having them decide where they're headed. And in doing so, they do want good decisions for themselves. And if you can give them the tools to help them do that, a lot of times they'll self-correct their use. They use less when they're less stressed. They use less when they're feeling happier. They use less when their relationships are going better. So if you focus on the bigger picture, the substance use still remains part of the process. And we were able to show that to stakeholders involved and say, we may not be going directly at the substance use, but we're still getting to it. So we got buy-in as well. And we've been able to continue to sell that model because substance use improves over time with going about the full picture.
Awesome. Thanks so much, Rebecca. Evan, I know you have thoughts on this.
Yeah, these were awesome answers, and I don't want to repeat any of the points folks made. I'll just magnify a couple things. Of course, from an engagement standpoint, it's ludicrous if your goal is to engage a young person, not to recognize who they are in front of you and appreciate the whole kid and ask about their strengths and resiliencies. I think from a clinical standpoint, the horse is way out of the barn, that substance use is not something to think of in a vacuum. And I think, a couple of folks made the point that from a preventive standpoint too, it's if you're only going after, the clinically significant and sort of intervention worthy element of what you're asking, you miss opportunities, you miss levers and strengths and opportunities for prevention in an individual kid's life by understanding what they want to do and what they're motivated by. So I won't hammer those points. Those I think all are true. A couple of things that I think are also interesting about this is this again, you'll hear this theme from me. Our focus is on the people who do SBIRT and on the systems where we embed it, is that the impact of only asking about substance use in a setting where a kid can get in trouble is also problematic for the kid. But if you expand the inquiry, expand the question set for the system and the people asking the question, it immediately changes the way you look at that young person. So you're not looking at a kid as a user, but you're looking at this young person as someone who was on the football team and aspires to be on it again, or a kid who is, kind of afraid of getting in trouble, or a kid with a lot of assets. So it really is also about, and again, this is very salient if you work in justice settings or where justice is kind of on the table. But I would argue that that's true in school settings too, where justice and discipline are on the table, and so is stigma and acceptance and otherness. So I think a program that is holistic and where SBIRT is holistic has a strong impact on the culture of the community and on the climate and the way kids experience safety and a willingness to talk. So.
Great, Evan, and you're leading us into my next question, which I know we've partly already addressed, but just to really hone in on that idea that it's not sufficient to just drop in an intervention without also addressing the whole environment in which young people exist. I'd love to hear more from you guys about how context, so developmental, cultural, socio-political, influences adolescent SBIRT, and what are the implications for health equity in the adolescent space. Let's start with Bree this time.
I think, again, like thinking from a systems approach, like we're, at least from my work at the national level, like we're having different conversations about, engaging marginalized communities, how we have different motivational interventions with different populations, how to adapt. And I think, at least in my time working in the field, I think that this is the time to have these challenging conversations and to challenge the way that we've traditionally implemented things, and to have a broader perspective on how we engage communities and populations, and how we just utilize this opportunity to branch out the way that we have been thinking about things. And I also think that, again, like I'll echo just the opportunities with some of the national dialogues that are happening, and how do we, again, like, how do we grab a hold of some of like the CBHCs, the Certified Community Behavioral Health Clinic, a lot of political buy-in, a lot across both parties, a lot of support. We're seeing millions and millions of dollars being invested in the CBHC community, which with the primary goal to increase access to quality mental health and addiction services. That is the number one aim of CCBHCs. So as part of that discussion, how do we ensure, as like expert advocates on this line, that that is just part of the discussion, because there is so much political buy-in on that model in general. So I think it's a strategy piece, and I think it's for all of us to really understand like where those levers are, and then to just kind of hitch on to those initiatives and have that conversation. We do a lot of advocacy at the National Council. We support our members. We have just about 4,000 members who are mental health and addiction organizations across the country. And we encourage them to have these conversations with their political parties and engage in that discussion. And I think, again, we're just in a different time as it relates to healthcare and diversity, equity, inclusion. And I think we can have these conversations in a really meaningful way.
Thanks so much, Bree. I feel like Evan really wants to answer this one, so I'll start.
You felt that. Yeah. So, one thing I want to say, just to start myself off, is that I feel like in society, in a lot of ways, for the most vulnerable populations that we work with, and I think, so I'll decode that phrase that we keep using. We mean people of color and people of poverty, is that for those people, we have kind of kicked the public health function downstream into systems like child welfare and youth justice, and created and maybe done so, you might argue, because we've also at the same time divested of resources from the communities where those folks live, and where their wellness and their protective factors and their kind of the social determinants of health, to use a public health jargon, where that stuff used to reside, but resides less so. That we have created a situation where those public health functions have been kicked downstream into juvenile justice. That's where the screening is happening. That's where some of the best evidence-based practices are delivered. I used to run a program in New York City that was based in the home-based. We were the only, and Brett will know this, for many years, we were the only home-based licensed substance use program for adolescents in the state of New York. And but where are the resources, and where are people expected to receive their support? And so what it engendered was this sort of abdication of responsibility of communities, a kind of a paralysis and a numbness, and a giving over to the systems to take care of our kids. So I think part of the answer is to try to kick those public health functions back upstream, and schools are a wonderful place for that to happen. I think some people might see, people who are new immigrants, first-time Americans, might see schools as a threatening place to receive support and public health services, or, for someone to notice that their kid needs help might be a threatening event for them. But in general, schools have the potential to be an awesome public health bridge to community and to culture, and to be a place that welcomes families back into a set of resources that have been kind of vacuumed out of their communities. And so that may be too philosophical an answer for you, but I think just the generally situating this back in a community context, and treating schools as community and as bridge to community, inviting community into school, is kind of the answer to how to do ESPERT in a way that brings equity about.
Absolutely, Evan. Yes, and I feel that, because obviously working in the School-Based Health Center world, this is exactly what we advocate for, is getting so much farther upstream. I'll let Rebecca answer now.
That's a perfect transition. I couldn't agree more. And when I think about this question and the context that we address ESPERT in, and how it can move us further upstream and increase that health equity, school-based health centers are doing it. And that is where I see so much potential with the model. I think that, in a place where there's less stigma, because it's about healthcare. You go there to be well, and working on shifting that concept of well care instead of sick care. School-based health centers are able to slip this stuff in and make it a normal part of practice. And so they can do SBIRT while they're doing a well child check. They can do SBIRT at a sick visit. And so I think that by doing that, you recognize that it's just a normal part of addressing health to ask these kind of questions. And it also gives you a place where you can be consistent in using SBIRT across issues. So we use SBIRT to address substance use. We use SBIRT to help the family work through an asthma plan. I apologize. We also can increase, I think health equity comes to mind a lot when I think about school-based health centers. You bring the services to the youth. So by being able to say, we're here, our doors are open, it allows youth who in many states are able to access substance use treatment on their own from an early age. It brings that empowerment to them. It takes down barriers of transportation by having these services on the school campus. So I think that when you start to wrap it into services that are already existing, and you start to normalize it, then you really do meet folks all along the way in development, and you create that equity across different community resources, and you're able to do more of that prevention work and still wrap in the interventions as you go.
Thanks so much, Rebecca. And no worries about pets and children joining us. Lots of grace for that. Let's go to Byla next.
I think context is really important when it comes to addressing these issues, because especially with youth, there's going to be different reasons for different people as to why there's different issues when it comes to substance use and substance misuse. And I think Rebecca even mentioned, like, it could be a mental health issue, or it could be a family issue. There's just so many things that go into it, and it's very complex, and it's not just a one issue. So with the video game, since that's what I'm working with, it's a way that when it comes to like health equity, everyone can have access to it, especially in schools. Everyone can have access to the information when it comes to how do I advocate for myself when I go to the doctor's office? What do I say? Or even how do I get access to the resources so that I have the right doctor? How can I look for mental health services? Because there was even a sect where the player doesn't get the mental health provider that is the right fit for them. And most people right after that, you'd be like, okay, kind of go through the ropes of, okay, how do I find the right fit? And I think that's also an issue with youth, especially with mental health, and especially during the times that we're in right now. It's really important. So it's just knowing that, again, it's very complex and there's different steps that go into it, but it's a way to help guide youth in those steps where they might not have a guide where they're at. And this is all happening in school and in a way that is also, I guess, fun. It's like fun to learn about how to advocate for yourself since it's a video game. So yeah, I just overall just want to emphasize that context is really important, in the background and the different things that go into why different youth, why, like the reason why people go into substance use in the first place, and addressing each of those ways in a way that is unique and guides them.
Thanks so much, Byla. I know Emily's going to put a link in the chat as well to a study that kind of showed how school-based health centers can address health equity. So we'll share that as well. Brett, same question to you.
And I did want to kind of respond to what Rebecca was saying, and I I totally agree about the school-based health centers creating equity, but the only issue with that, and I talked about New York State having this huge network, is that there's so many other schools, so many more, that don't have school-based health centers. So, and then when you look at the schools in general, not everyone, we're not on an equal playing field. And this goes like totally back, like you know how schools are funded through property taxes, and you're going back to communities and income and all of these issues and these social determinants of health. So we're dealing with a lot in context. And so one of the things that I've been focusing a lot on is the rural context. So particularly with mental health, suicide risk, as well as substance use and opioid and other drug overdose, there's a great risk in rural areas. And we know, some of the reasons for these things: lack of services, lack of providers, transportation issues, long travel distances, and there's just a great deal of poverty there. And so I have been doing this, and actually still doing this, rural listening tour at New York State. And unfortunately with COVID, we're making these virtual stops now instead of in person. But we're hearing, lots of different things, and some of them is just that they can't. People in some of these communities lack just the basic life and job skills, not knowing not to show up to an interview in ripped jeans, so that they don't get the jobs that are open in their county, and they've got people coming from outside the county to get those jobs. And because they don't have that regular routine, it's causing mental health issues. And in a sense, like the participants said, like, they're bored, so that just leads to substance use and domestic violence because there's nothing else to do. So you're dealing with all of these issues, and some of these issues are also in urban areas, but it's happening within that rural context. So basically, kind of, you need to look at the specific community rather than kind of the trying to put labels on things. So if you have like specific populations, like demographic populations, you need to hear from them in order to create a model of SBIRT or whatever we're talking about that meets that community. So I wouldn't say that, American Indian, Alaska Native, like SBIRT model, or a African American or Black SBIRT model, or rural SBIRT model, or an urban model. Like, you can't, it's each community. So I think what's critical, and the feedback that I've gotten, is that communities want to be heard. They want a voice in their in the development of an intervention that is tailored to them. And I was actually at the American Association of Suicidology conference last week, and there was just an amazing keynote speaker that represented the American Indian community. And she was just talking about how they recognize suicide risk being so big in that community, and CDC sent in lots of money and their people to look into what the reasons were and to write up this report about how bad things were, without looking at like the positive factors. And then they're like, okay, this is what it looks like here. And then they left, and then nothing happened. So so that coming in, getting information from the community needs to lead to something that the people within the community have a stake in and they're involved in.
Great points, Brett. Thank you so much. I'm going to move to our next question. Just so you all know, we'll allow some time at the end if you have follow-up questions or comments on any of these great discussions. We'll have time for the panelists to kind of add comments, and then we'll have time for Q&A at the end as well from our attendees. I'll go to Byla for this one first. So how has the pandemic and the events of the past year changed or raised consciousness about how you do your work or the directions you want to go, if anything has changed about your work due to the pandemic?
Yeah, I think that the pandemic has actually solidified the need for like the upstream models and more advocacy, because a lot of times we've seen mental health issues that were already prevalent worsen, or a lot of stress. For example, now a lot of schools online, so a lot of kids are struggling with school, they're struggling with the social isolation. All of the different factors that we all talked about are now being more and more of an issue. So I think that with this time, like with the COVID situation, it has also also in a good way, also highlighted how flexible we can actually be with the like virtual situations. And like for the video game, for example, it can be something that can be virtual. And like they did different testing and different focus groups. All of that was virtual, and getting youth feedback, and connecting with different schools, and also connecting with different youth all around the country, and allowing them to also provide their feedback on the game. So that in itself was was a sort of a plus for the virtualness, just the access. But I also want to highlight like the link between addiction and stress, and how specifically for youth that is one of the one of the many factors that go into it. And like I said, just mental health in general has become more and more prevalent, and there's almost a normalization of it because of the fact that everybody's collectively, there's a trauma collectively, everyone is struggling with all of this. Yeah, so I think although the COVID has been really, really harsh, it has also brought to the surface a lot of the issues that nobody really wanted to talk about, but now we're forced to talk about that, and it's a good way because it's allowing different models and different ways to have an approach that is more holistic and more helpful than in the past.
Thanks so much, Violet. I love that. Let's go to Brett next.
Yeah, I mean, there are a few different ways. And so one of the things is telehealth. So it was so difficult to get like, and I'm going to talk from the New York State perspective. I was talking with one of the large school-based health center organizations there yesterday, actually. And they were saying that, how long it took OMH, Office of Mental Health and Office of Addiction Services and Supports. It's so difficult to kind of make any compromise with telehealth, along with like the regulations that service providers have. And with COVID, all of a sudden, it just became so easy. Like, there you go. Because I guess they had to do it. So all of a sudden, it wasn't that difficult. So with telehealth and school-based health centers, like even though the kids are there and it's easy access, and essentially they just get like a pass and come down, as opposed to having to have their parents drive them or drive themselves, and all these reasons not to make the appointment, a lot of times the kids still don't show up. But with telehealth, the actual the number of appointments that are actually, the show rate is so much greater now during COVID with the telehealth appointments, that there's just the increase in actual appointments just across the board. So I think that's one of the things that, whereas it's a terrible thing that happened, at least it's just more open to telehealth, and adolescents, kids are open to using these services, and of course, probably more than adults based on their comfortability with technology. The other thing too is, we talked about consciousness, and I think we're looking about trying to better understand specific populations. We've for some time have kind of identified, okay, there are different risk factors in different populations, but how much did we deeply understand that? And that's something that's really resonating in my work. As I was telling you about kind of like this rural listening tour that we've been doing, you see all these negative things, and you wanted to say like, hey, like, look how bad things are for these people. We need mental health services. We need substance use disorder treatment services here. But you need to, I'm feeling more and more like we have to show the strengths and the resilience within the community when we try to express the needs. And so that's like, so I'm like in the middle of trying to develop a report for New York State to get them to kind of see what the needs are. But how do I, more recently, how do I frame that so it pulls in the strengths of the communities, and not just like, as you could say, like the dire need that's there. I mean, there is a great need, but it needs to be framed in a more positive way.
Thanks so much, Brett. Let's go to Evan.
Took me a year of the pandemic to find the mute button. But so, a couple of things stand out for us. I mean, the pandemic was a massive disruption of the community connection that schools have with families and kids. It was an immediate, snipping of that positive pathway and umbilical cord between schools and community and family. So in our work, we have two major projects going on. We were in partnering with King County in Washington State, working in 50 middle schools and seeing a pretty well-developed and very effective SBIRT program using this awesome new screening tool called Check Yourself. It's an app-based tool that kids really trust, feel connected to. It's kind of this, it's got this built-in kind of empathy and feedback. Suddenly having that way of having kids communicate in a way of, finding out how kids are feeling and building a connection, suddenly that was completely cut off. So that's not, that's not breaking news that the pandemic did that. But what it did for us was it forced us to look at that connection and to look at who else in the ecology of the school community relationship were important, and it really elevated the importance of our community partners in those moments. And many schools have really important community partners, organizations that come from the cultural and ethnic communities that populate their schools. So we began looking to those entities, those organizations. There's a great vignette in a meeting that I repeat this anecdote all the time, but there was a multi-tiered systems of support meeting at one of our schools, and someone brought up that there were about 10 or 12 kids that seemed to be lost to contact, that they had been screened prior to the pandemic, that there were some mental health concerns, that they're not showing up on Zooms. And our community partner for our project was in that meeting and just thought to say, well, what are the names of these kids? And so they kind of read down the list, and he said, I think all of them are in my office right now. And they're actually, so, we have all these engaging programs, and the kids may not be showing up on Zoom or not comfortable connecting in this way, but they're here with us in our gym. So just to, so we really, not that we didn't know it, but it really highlighted the importance of the community connections. And the other thing that it did, and I think, others have mentioned this too, is just the enormity of the stress, the amount of loss that there was, and the amount of food insecurity, economic insecurity. What I've heard called racial trauma, all of the Black Lives Matter and the elevation of our awareness of racial inequity and police murder, really re-traumatizing communities. So the public health impact on our kids was enormous. And I think, Brett talked about some of the positives. And one of the positives that made us really aware of the importance of adolescent mental health. And the federal government is mobilizing billions of dollars for schools for next year. And if people on the call are not aware of that, they should sort of learn about where those big statewide block grants are coming from. It's not required that they address mental health in those block grants, but it's one of the categories that you can spend that money on. So I think it really it was a huge consciousness raiser for us about the fragility of adolescent mental health and the things we can do at the school level.
Awesome, thanks, Evan. Let's go to Bree.
Yeah, I mean, I would just echo, I think, what Brett was talking about with telehealth, and also these hybrid models of care that are now emerging, and the policies that have been revised to support access to telehealth. I mean, I think something that we're certainly focusing on is how do we protect those policies changes for a positive, like moving forward as things sort of, hopefully improve with the pandemic, but we want to see some of these initiatives continue. So advocating for those policies to remain around protecting and access to telehealth and hybrid models of care. And then what I've also really been involved with at the National Council is all of our training, mental health first aid, trauma-informed care and resilience. We have a lot of trainings and technical assistance, but we, as you probably have, many of you on the call have shifted to all virtual provision of these trainings. So I think there's access. It's more accessible, these trainings, and how do we work smarter and more efficiently to get these trainings and evidence-based practices out to the right communities. I think we have more opportunity to do that now, as we certainly will continue to provide virtual training as well as in-person training, probably a hybrid approach. But I think it's even more of an opportunity as we work smarter and harder to reach these communities that typically haven't, engaged with us at the National Council for Training and TA. So I do think that there are these opportunities as well with the pandemic that we just also have to protect and continue moving forward.
Thanks, Bree. And I know we've talked a bit about with the new funding coming down and the CCBHC model, and is there space there to advocate for school-based services as well? Again, for us, whether that's a school-based health center or getting those adolescent mental health services in schools. I don't know if you want to say any more about that, but.
I mean, I think one of what oh, go ahead, Emily.
Would you also mind to say what a CCBHC is in case someone on the call doesn't know?
Yep.
Thanks.
So CCBHC stands for Certified Community Behavioral Health Clinic. And if you are familiar with the federally qualified health centers or F2HCs, I think of it as the sister model to the F2HCs, but for mental health and addiction services. So for the first time in history, we have this standardized approach to providing mental health and addiction services that's required in statute, and that is also sustainably funded through a Medicaid prospective payment, basically a Medicaid global payment for services. So there are currently 370 CCBHCs across the country. We anticipate that this will just become all behavioral health, all mental health and addiction organizations will become CCBHCs. And what's really unique in the opportunity I see with school-based health centers here is that CCBHCs are partnering with law enforcement, hospital settings, food banks, school-based health centers. And what we're doing is we're measuring sort of the public health impact to these collaborations and partnerships outside of the four walls of the clinic to really address mental health and addictions from a public health perspective. And so I think that the opportunity here is those partnerships between school-based health centers and CCBHCs, because CCBHCs can really work to treat when somebody has a more serious mental health or addiction issue than a school-based health center. So those referrals, right? What we always hear with SBIRT is like, I'm not going to screen if I don't have anywhere to refer. I heard that just the other day, and I thought we had addressed that like many years ago, but that is still very real and very much an issue. And I understand that issue, because it's like somebody said to me, why would I treat a broken bone if I can't heal it? It's the same thing. So, but if we create a better and more comprehensive system of providing mental health and addiction services through the CCBHC model, that issue will no longer exist. There will be a CCBHC in every community across the country. So I think the opportunity here is just bridging the school-based health centers and the CCBHCs within those communities.
Thanks so much, Bree. Yeah, echoing Evan's comments about community partners. I'll pass to Rebecca now.
I think a lot of what's been said is what we've seen as well throughout the pandemic. School-based health centers, I felt were at really such an interesting crossroads with the impacts of the pandemic, because you're talking about healthcare organizations in schools. And we know schools were heavily impacted by shutdowns, and healthcare was heavily impacted just by the load that these organizations have carried and the need that they've tried to address. So I think when we kind of looked at all the programming work that school-based health centers in our state were doing over this past year, what we saw is programming fell to the side, because there was a need to address what was in front of them. So a lot of opportunities are certainly there. I think in coming out of the pandemic, telehealth has been a really interesting one to follow. I've been surprised at how little interest we have seen for school-based health centers to really embrace it. And at the same time, I've also, really heard that they exist where they are because they want to be where the kids are. And so I think there is a lot of potential and a lot of questioning right now on what does this new technology mean? How can we use it to connect? How do we educate our families and patients on this, especially those who telehealth is not equitable? It requires devices, it requires connectivity? How do we approach that in an equitable standpoint? How do we use it to expand to places where there aren't school-based health centers? What community partnerships need to happen? So I have seen more questions come out of the pandemic, especially in the last few months. People are starting to shift back out of crisis mode and into, oh yeah, this is what we do. Things like, how do we screen remotely? That's been a huge conversation for our school-based health centers. They're beginning to gain access to some remote screening tools, and they're also very hesitant to use them. Saying, if we screen, what if that kid doesn't show up? What do we do with that? How do we connect them? And so I think right now, the need is clear. As everyone's spoken to, we've seen the heightened need. Regulations have changed, technology is expanding. I think there's a lot of question. So within that, I think there's a lot of opportunity. I also kind of view a break as a chance to say, you don't have to step back into things the way they were. So I think school-based health centers right now have the opportunity to look at how they resume services as they start to do that in person, how they expand their programs as they move forward. It's a great chance to reset to a new normal. So those are some of the things that we've noticed in our work, which is really, it got put on hold during the pandemic, despite the rising need. And now that it's coming back into play, there's an opportunity to put all these new resources into where they fit. And I think that'll be a few years in the making.
Absolutely. Thanks, Rebecca. I know early in the pandemic, our president said that all the challenges aside, that this is an opportunity to reimagine how we're doing everything to serve young people. And I keep thinking about that. How can we take advantage and move forward in better ways? I want to expand the question now to just kind of include, pandemic aside, what are the major challenges you've experienced with doing this kind of innovative work? So, adapting the SBIRT model to kind of address young people's needs more holistically, and how have you navigated those? So let's go back to Rebecca. We'll let you lead this one.
So I think that the talk of resiliency and being more strength-based that I've heard pop up throughout this panel is an area that I see a lot of work moving, as well as taking in just that more complete picture of the youth in front of us that we're working with. So we're not treating little things really specifically, we're treating the whole individual with a very wraparound approach. And I think part of that wraparound approach and part of that whole person is honoring their strengths, honoring their resilience. Our youth are incredible coming out of this pandemic. And I think that it's an opportunity to really empower youth. And I think SBIRT is really set up well to do that. So a lot of the programming that we're looking at is we have some projects around resilience and ACEs, and it's how do we continue to expand that further out? How do we make that a bigger project? And I think SBIRT is probably the next tie-in to that. So using some of the healthy outcomes from positive experiences, hope research, using healing-centered engagement as an expansion of trauma-informed care, and starting to work these into what brief interventions look like, looking at when you're referring, are you referring to support? Are you referring to things that are going to continue to increase engagement and resilience? So that's the direction of SBIRT that I see us headed.
Awesome. Thanks, Rebecca. Bila, how about you? Beyond kind of the pandemic, what are some of the challenges associated with adolescent substance use prevention work?
Well, just like adolescent substance work in general, I think the main challenge is almost learning how to speak the language that you speak, because we respond to different things very differently. and it's not the same as I'd imagine, like being a provider to screen an adult versus a child. I think like Rebecca, you brought up like you want to be able to be on the team, but like we want to address the issue with either vaping or whatever the issue was. So like there's a need to like connect youth's interests and what they respond to with also what's good for them, or if that makes sense. But more specifically into the work that I was doing, the main challenge that I can speak for was just making that language in the game in a realistic way, so that it didn't come off as too like don't do drugs or don't don't do this, but more in a way that like is very realistic to what the situations that youth experience. And also there was one part that I had a struggle with, like providing feedback on the conversation that the player would have with a loved one that had a substance misuse issue. And that's a really difficult conversation to have. So how do you navigate that? What are you supposed to say? How do we make this how do we make this come out non-judgmental, but also assertive in a way that really makes the person understand here are the issues and that you need help? Or but those are like the challenges I mainly face. I can't speak for like the whole like the background of it, because I only came on for, again, providing that feedback. But yeah, those are like minor challenges.
And I think, Bila, something that I know you and I have talked about, and you mentioned earlier, is that I think part of what's so cool about the Play to Prevent work is that youth are engaged in sort of doing a reality check, right? Is this realistic for young people? And I think something that can be a challenge for organizations is recruiting youth and hearing youth voice. And something we talked about is like paying young people for their time the same way that you would pay adult consultants for their time. And so when you were talking about that so much of your work was about making sure that this is meaningful for young people, I was thinking about like pay young people for their time. So just a plug, if you're on the line, find some money, pay young people who are sharing their expertise with you.
Yeah, that's a really good point, because also with the focus groups, like it's an opportunity to allow youth to speak about the topics that directly affect them, and kind of have that voice, because I think a lot of us are scared to like voice our opinions. So yeah, that's another point.
Thanks so much, Viola and Emily, for the plug. I think probably many of you are as impressed with Viola as we are, and there are lots of other young people like Viola out there. So yeah, definitely accessing. I feel like we hear a lot in our work, nothing about us without us, and I think it's key. If you want to work with young people, you should be involving young people. So we huge thanks again to Viola for participating in so many of our projects. I'll pass the question to Brett now.
So I think, and I'm going to talk specifically about the, adding the suicide prevention work into the SBIRT model and what those challenges are. There, of course, there are competing demands, and just adding another screen also kind of, it raises challenges among providers. And then on top of that, whereas substance use is a sensitive issue and it's very serious, suicide is specifically like a very scary issue for providers to deal with. And if they don't feel comfortable with, if someone screens positive and they don't feel comfortable with that, they just may never screen because they don't want to know what the result is, and they're afraid that they could make a mistake and that someone can end up taking their life. And that they also fear that blame could be placed on them, like their liability issues. It's really critical to have the organization kind of take full responsibility as it being not the burden or the responsibility of one person, but the entire organization. So that providers themselves individually don't feel like it's on them. So to be afraid to address something is just a major barrier to ever implementing or delivering any kind of service. And this service is really critical. And I feel like the other challenge is that of funding. So you see that, if you look historically at the SAMHSA SBIRT grants, you see, yeah, at a certain point, they suggested screening with the PHQ-2. So to cover, like, if someone screens positive on that PHQ-2, to provide a referral for any kind of like depression care. And the latest FOA, which just closed, they actually had suicide screening. They suggested that in the FOA. So, I mean, I think there's positive movement, but it was only recommended, and you need to do more than screening. Like, there was nothing about what you would do if someone screened positive. And if you do screen for it, you need to have something in place, but there was really nothing about it. So if that's not supported, and the amount of funding that they're giving is less than it historically has been, there's really no way that applicants are going to fit that in. So there's all of these challenges. And then you also have SAMHSA's different centers, and it's like SBIRT is the responsibility of the Center of Substance Abuse Treatment. Suicide prevention is Center for Mental Health Services, and they can't cross. So those are the problems and the challenges that we're going to face. And you need to have an organization that really sees this as a problem and can provide not just the proper training, but the support, the clinical supervision, and the environment that they can practice their skills before really going to work with patients, and then to provide that support along the way so that they feel more comfortable. If there's an organization that's willing to take that on without those funding sources there, that's what you're going to have to find. And if you can find that.
Yeah, thank you so much, Brett. Let's go to Evan.
I first want to just respond to something Linda just said in the chat, that the liability is when you don't ask the suicide question, just to jump into Brett's topic. And when we started doing SBIRT remotely during the pandemic, we figured out a way, after a lot of planning and figuring out the necessary preconditions to do this check yourself in a Zoom setting so we could continue doing screening. The major pushback was this fear of asking the suicide question. And I think the consensus was what Linda just said in the chat is like, can we afford to not ask the question? Should we just be asking, what are the preconditions necessary so that we can? Do we need to know a little bit more about mom's whereabouts? Do we need to know the school's safety plan, or do they have a safety plan? So it helped us to mobilize some great organizations in and around the school districts where we were working that do great trainings to help a school develop a suicide safety plan. A lot of people, it's paralyzing to think about, and a lot of people prefer not to ask. But anyway, so the challenge, other than just sort of the pandemic challenges, are that implementing this stuff is really complicated. So I think if you just look at this panel of advocates and experts and people who have succeeded in implementing these kinds of programs, you might forget how complex and how much readiness and preparation and planning is required. And so we've really learned, we've been at this for a while, that you need to allow for a period of planning and take the concept of readiness to implement really seriously. Do you have referral networks? Do you, and the buy-in? A big part of readiness is buy-in. And I'm not saying that it was a significant barrier, but you do find that counselors who have not been working in and around an SBIRT program as the centerpiece to how they determine who needs support in their school building can be a little bit threatened and kind of daunted by the idea that there's going to be a new way of making decisions and engaging. So you do really need to sell this idea. We have a ton of data now. We know that about 30% of students who are identified as needing a referral were previously unknown to counselors in the building. Super powerful statistic to bring to bear when we enter a new school to talk about SBIRT. So just being aware of what goes into that. The other piece of it is, this isn't the only game in town, and I think, or in the school building. There's a lot of initiatives around social emotional learning, positive behavior interventions. Schools do a lot of really effective school-wide stuff, and SBIRT needs to fit with what they're doing. So to make part of the conversation, the implementation conversation, this question of how do we make this stuff fit like a puzzle piece with what you're already doing? And maybe anticipating this last question, but we've developed this new model that kind of asks that question: is how does SBIRT fit in with school-wide interventions like restorative practice and social emotional learning? And so I can talk about that again later, but you really need to address this idea that this stuff can't be just airlifted and dropped in and suddenly you have a program. It's very complicated, but doable.
Yes, yeah. Thanks, Evan. Bree, anything to add to this question?
I mean, I think I would have answered the same question the same like 15 years ago in terms of just prioritizing prevention. I've largely worked for mental health and addiction organizations that typically focus on the end stage of the disease of addiction. So how do we just continue to have that conversation about the importance of prevention at all stages? And then also we're all talking about how to use SBIRT as a framework for other illnesses besides substance use, but also not losing sight of the original intent, which was alcohol use. And, some of my training with providers has largely focused on those are sometimes the hardest conversations to have around alcohol use in particular, because it is, a norm across our society. So not losing sight of the importance of really the number one killer in terms of alcohol use. And we do ECHO collaboratives. We run them out of our Center of Excellence at the National Council. And we had one on the silent killer, alcohol use. And it was the most largely attended ECHO collaborative. Which just elevates the importance of still having conversations around the harmful effects of alcohol use.
Thanks so much, Bree. And I know we're getting close to time, so I'll ask for, if the audience has any questions, feel free to put those in the Q&A or the chat, and we'll try to get those answered. I wanted to give our panelists an opportunity to kind of offer some final comments, maybe consider what do you see the next steps for the SBIRT model? Are there innovations you're really excited about? End on a high note. But would love to hear your reflections. So let's start with Byla. We'll go back to
Byla. Yeah, so I think the game in general, like I've just been saying, it's definitely been an amazing process for myself, just because of my personal interest in substance use and adolescent health. So it's definitely a way for me to also expand my interests. But I think in general, like the most important part is for me, I think prevention, and just emphasizing that, and allowing the understanding of like the holistic way and viewpoints of how youth go about, I guess, the route that it takes to end in substance misuse or even overdose, and then going backstream almost and saying, okay, where can we prevent all of these issues? But I saw someone say something in the chat about where you can get the game. I have a link, but I think that yes, thank you, Katie. That's perfect. There we go. So that's the link to where you can get the game and test it out. But yeah, it is still in development. They just had focus groups. So yeah.
And they have several other games available that you can access now. So yeah, feel free to reach out with them, and more to come on the game that Byla's working on right now.
Yes.
Thanks, Byla. All right, let's just open it up broadly. Any other comments or final words from panelists? I know Rebecca said she's covered her thoughts. Anyone else want to?
Yeah, so with the SBIRT model, we talked about universal screening and these general medical settings where people go more often than substance use disorder treatment. But still, people aren't going necessarily to these settings either, some of the hardest to reach populations. So when we talk about school-based health centers, a lot of the kids, and when I did even the pilot work back at the beginning of my work in school-based health centers, they said the highest risk kids, they don't even come to school. So there's no way we're ever going to reach them. So how do you reach out and deliver ESPER? And one of the things that, you know, in our rural listening tour, we also heard was that we really need to go into the community where people are, because there's such a stigma in some of these settings and people aren't coming to access these services. But we can't do that because of reimbursement models and regulations. So is this one physical location where we can get paid for the services? So developing a model first where you can outreach and find like these kids who aren't coming to school, so will never get services in school-based health center. And a second, how the provider can get paid so that is sustainable.
Great points, Brett. Thanks. Any other comments from our panelists as we conclude? Evan or Bree, any final thoughts?
Yeah, if you don't mind a moment of semi-shameless self-promotion, I would just say that you know, having experienced all of these important building blocks, and I think shared by a lot of the panelists, this idea that community engagement is important, that integrating with existing initiatives